content today is first I'll talk about cardiac innervation, then cardiac electrical activity. Then we'll look at the skeletal versus smooth versus cardiac action potential, then antiarrhythmic classification. And very quickly on antiarrhythmic classes and mechanism of action, the important points. Then I will discuss few SAQs. So this is the core recipe, the antiarrhythmic classification that we have, class 1, class 2, class 3, and class 4. You have to know 1 or 2 examples for each classes as well. So we'll come into it. Autonomic innervation. Okay, my slides on cardiac autonomic innervation is I made it quite very simplified, as in for answering SAQ, not to get 10 out of 10. This is how to get 5 or 6 out of 10 because it's quite a broad topic and very quite complicated actually. So we'll just make it simple and take important points. So the autonomic innervation for cardiac starts from origin from the medulla at the nucleus of tractus solitarius. So this is the origin. Okay. Then they have sympathetic and parasympathetic. So sympathetic is cardio acceleratory. It means it's stimulatory to the heart. So there are a few nucleus here. I didn't put the full form. This is caudal ventrolateral medulla nucleus, CVLM, caudal ventrolateral medulla. It's all from medulla, right? So which part of the medulla? Which side of the medulla? Okay, its origin from the caudal ventrolateral medulla goes to the rostral ventrolateral medulla. Then it goes to the intermediolateral nucleus. Okay, I think if you don't know this in specific, it's okay. You can just write from medulla at nucleus tractus solitarius, straight away go to preganglionic fibers. I put this here for my knowledge. Okay, so it's from CVLM to RVLM to intermediolateral nucleus. So it goes via a preganglionic fibers, which neurotransmit as acetylcholine. Then it goes to postganglionic fibers, where your neurotransmitter is norepinephrine. And that forms the conduction system in the heart when we will come to the conduction system of the heart. So the origin and the pathway to reach the heart is from the medulla at nucleus of tractus solitarius, goes through a few more nucleus, and then via preganglionic fibers using acetylcholine reaches the postganglionic fiber where norepinephrine will act on the conduction system of the heart. Sympathetic is cardioacceleratory. Whereas parasympathetic is cardio-inhibitory, meaning it slows down the heart conduction, slows down the contractility, slows down the heart rate and everything. So where it starts from nucleus ambiguous. Okay, so both of them origin is from nucleus tractus solitarius, but for sympathetic it's this nucleus, whereas for parasympathetic is nucleus ambiguous plus this is dorsal medial hypothalamic nucleus, DMN, if I'm not mistaken, DMN. Please Google and see. But it's okay. If you don't remember, just put nucleus ambiguous is more than enough. Okay. Nucleus ambiguous goes through your vagus nerve. Okay. This is your pathway. This is the track that brings down vagus nerve via preganglionic fibers, again acetylcholine, and postganglionic fibers, also acetylcholine. Sympathetic, preganglionic acetylcholine, postganglionic norepinephrine, whereas for parasympathetic, preganglionic and postganglionic both are using acetylcholine, and then they affect the conduction system as a cardio-inhibitory effects. Okay, this is the simplified version, the summary of autonomic innervation of the heart. So again, this is the medulla. Okay, in your medulla, you have nucleus tractus solitarius. That is the origin for sympathetic and parasympathetic. Then follow my arrow here. You have sympathetic pathway, caudal ventrolateral medulla, rostral ventrolateral medulla. Then you have an intermediolateral nucleus, preganglionic fibers using acetylcholine. At T1 to T5 fibers, sympathetic fibers, it's a sympathetic postganglionic fibers. This is sympathetic preganglionic fibers. Sympathetic postganglionic fibers is on T1 to T5, which comes for secretes norepinephrine. It has a cardio-acceleratory effects on the heart at the. It acts on the SAN, it acts on the ABN, and it acts on the Purkinje fiber bundle of branch. Okay, so the bundles as well. Whereas your parasympathetic, again from the medulla, the origin is from nucleus tractus solitarius. It goes to your mainly to your nucleus ambiguous and also your dorsal medial hypothalamic nucleus, DMN. Then it goes through your vagus nerve, preganglionic acetylcholine, postganglionic acetylcholine, and has the effect on SAN, ABN, and directly on the ventricular muscle as well. Okay, cardio-inhibitory. This is in the picture form that what I explained it earlier. Hope this is clear. So once the nerves has reached the pathway from the origin, it reaching the heart, they forms a plexus. Okay, they forms plexus before they actually affect the conduction of the heart. So network of nerve including both the sympathetic and parasympathetic system. It has superficial and deep. I'm not giving very detailed. I'm just giving very simplified forms points to understand this. So it has two parts, superficial and deep. Superficial located below the arch of aorta, between the arch and the pulmonary. Last time, this is a very famous MCQ question, multiple true false question, but you all have SBA. I don't know how this kind of points can be made into SBA, so I don't think so it's quite possible. But in MTF, yes, all these are possible, the location of it and everything. So located below the arch of aorta, whereas deep lies between the arch of aorta and bifurcation of trachea. It's beneath, okay, between the arch of aorta and trachea, whereas this is located below the arch of aorta. Okay, this is the difference. Innervation, the conduction system of the heart. They affect the coronary vasculature. They cause a vasoconstriction and vasodilatation of coronary vessels. And they directly innervate the myocardium of the atria and ventricle. So they affect SAN and ABN and bundle of Purkinje fibers and so and so. Then they also directly affect your coronary vasculature. They also directly affect your myocardium of the ventricular contractile tissue directly as well. Okay, this is the innervation of the cardiac plexus. Okay, so sympathetic chain ganglia, you have superior, middle, and cervical from thoracic T1 to T5. Okay, so this is the T1 to T5, whereas vagus cardiac branches again from superior, inferior, and recurrent laryngeal nerve. Okay, I'm not going in depth about all this. Just you have to know this. And if they ask you talk about cardiac plexus, make sure you have to be able to tell it comprises sympathetic and parasympathetic, and has two parts, superficial and deep. And it innervates the conduction system, coronary vasculature, and myocardium of atria and ventricles. So from cortex to hypothalamus, hypothalamus to medulla, okay, the nucleus tractus, this is just a repetition in a different format. So nucleus tractus velatorius, sympathetic, and parasympathetic is via vagal. Okay, so sympathetic affects your heart and vessels directly. Vagal also heart, inhibitory, and this is stimulatory. So we look at in this is just a repetition of this picture again. Okay, medulla, parasympathetic, vagal, preganglionic, and then you have your sympathetic, you have preganglionic and postganglionic. This is just a repetition. So let's skip. This slide, I'm not going to talk much. This is just the effects of parasympathetic and sympathetic fibers. I'm sure you all know about it, what they do. And afferent parasympathetic, afferent sympathetic, everything. I'll just share this slides to you all. This is just what are the effects of stimulation of parasympathetic and sympathetic. So next we come to cardiac electrical activity. So cardiac electrical conduction. So when I put here the sympathetic and parasympathetic, the pathway, the tracks finally comes to affect the conduction system of the heart. Either they accelerate, they either stimulate or inhibit the conduction system. So what is the conduction system of the heart? So this is the conduction system of the heart. The conduction system of the heart comprises of sinoatrial node, SA node, AB node, okay, both are in right atrium. Okay, then you have a bundle of His, then you have your right bundle branch and left bundle branch, which has a left anterior fascicle and posterior fascicle, and then your Purkinje fibers. Okay, there's another bundle called Beckman bundle, which directly from atrium to right atrium to left atrium. We come into it. So we have SA node, AB node, bundle of His, which divide into right and left bundle branch, left as anterior and posterior, and finally the final terminal branches are called as Purkinje fibers. So the depolarization will begin at SA node, goes to your AV node. From SA node, it can directly goes to left atrium via Beckman's bundle as well. But to ventricle, it follows the bundle of His, and then lastly Purkinje fibers. Okay, the Beckman bundle is a interarterial, okay, interarterial conduction pathway. Okay, overview. The conduction system, they transmit the signal generated by SAN. The SAN is the signal generator. Okay, from the SAN, it cause the signal goes through the multiple conduction pathway to can cause the heart muscle to contract. The pacemaker signal, the SAN is a pacemaker, right? Sinoatrial node. The signals travels through right atrium and it goes to AVN, then bundle of East, bundle of branches to Purkinje fibers in the walls of the ventricle. Purkinje fiber transmits the signals and contract the ventricle. Conduction system is a specialized heart muscles. They situated within the myocardium. Dysfunction of the conduction system is the one that causes arrhythmia. Okay, this is the basics of our topic, the antiarrhythmic. So the dysfunction of any of these conduction system is what affects in arrhythmia, whether it's a supraventricular or it's a ventricular, or it involves the Beckman's bundle where it causes your Wolff-Parkinson-White syndrome and everything. Okay, so these are the gist of it. So the components, as I repeated, SA node is a sinoatrial node. It's a natural pacemaker. It's in RA near the entrance of superior vena cava, SVC. And we have AB node, atrioventricular node, in interatrial septum near AV valve. They are not in the ventricle, they're near the atrioventricular valve. Okay, atrioventricular valve, not aortic valve. Atrioventricular valve mean in mitral valve. Sorry, tricuspid valve. Okay, on the right side, interatrial septum. Okay, and we have atrioventricular bundles, which bundle of his right and left. Left one got anterior and posterior fascicle, and finally your Purkinje fibers. So this is just repetition of the same thing. I'm not going into the details. So what happened, as I mentioned, the SA node depolarized. Okay, number one, the SA node depolarized. Then the electrical activity goes rapidly to AV node via internodal pathways. So AV node to SA node to AV node, internode, nodes, right? Internodal pathway. Okay. So during this time, purple shading in steps 2 to 5 represents the depolarization. So from here to here, the atrium and this part of the heart depolarizes. Okay, depolarizes. Then depolarization slowly spreads across the atria and conduction slowly slows through AV node. The depolarization spreads more slowly across the atria, the whole atrium. Then the conduction slows through AV node. It gives time for the atrium to complete the depolarization. And number 4, the depolarization moves rapidly through the ventricular conducting system to the apex of the heart via the bundle of East. Okay, and finally depolarization wave spreads upward from the apex via the Purkinje fibers to the whole of the ventricles and causes ventricular contraction. So from SA node, internodal pathways to AV node in the interatrial septum and near the atrioventricular valve. From the AV bundle, it slows down, gives time for the atrium to finish contract. Then it goes via the bundle of branches to the apex, and via the Purkinje fibers, it depolarizes the whole myocardial ventricular part of the heart. So this is again repetition in words. I'm not going into this now. I just want to highlight here the few things about the timeline. The action potential generated by SA node spread throughout the atria and its conduction velocity of 0.5 millimeter per second. Okay, so 0.5 meter per second. So you see, this is not that fast. Okay, 0.5 meter per second. But AV node slows through the impulsion conduction considerably to 0.05 meter per second, which allows sufficient time to complete atrial depolarization and contraction prior to ventricular depolarization contraction. Bundle of East, left and right bundle branches conduct the impulsion at very rapid velocity of 2 meter per second. Okay, you see, bundle of East 2 meter per second. Atrium is only, SA node is only 0.5 meter per second. The bundle branches divide into Purkinje fibers that conduct the impulses at a very high velocity of 4 meter per second. So Purkinje fibers has the highest velocity. This is again multiple true false last time. Purkinje fibers is the very highest velocity of 4 meter per second, followed by bundle of His, which is 2 meter per second. Then you have your atrial muscle, which is SA node, atrial muscle at 0.5, and AV node is the slowest at 0.05 meter per second. Purkinje, bundle, then your muscle, myocyte, either atrial or ventricular, and finally is your AV node. Okay. The time in second to activate the different region of the heart shown in green arrows. So this one not important. Atrial activation is complete within 0.09 second, 90 millisecond following SA nodal firing. After a delay at the AV node, septum becomes activated for 0.1 second. All the ventricular mass is activated about 0.23 second. If you calculate all these, will come around, I think 0.8 second. It is the same as your cardiac cycle, okay, somewhere around that. So this is how your action potential shows that. What I want to show you is SA node potential, which is your pacemaker potential, compared your ventricular muscle cardiac action potential, myocyte action potential, the differences. Okay, the slopes and the phases will come into it. Okay, there is, as the signal pass through from SA node until the Purkinje fiber, the action potential morphology will changes accordingly. This is how ECG is related to the conduction system. Your SA node, atrial depolarization initiated by SA node causes the P wave. Then with the atrial depolarization complete, the impulse is delayed at the AV node. That's why you get this PR interval. Okay, this delay is because of the delay at the AV node. Then ventricular depolarization begins at apex. From the AV node, the signal transmits via the bundle of ears to the apex. So ventricular depolarization begins at apex, causing QRS complex. So atrial repolarization occurs at this time. Then ventricular depolarization is completed. So that is your ST segment here. And then ventricular repolarization begins at apex, repolarization causing the T wave. And finally, ventricular repolarization is completed. So that is your after the T wave, T to P wave. Okay, this is the how the conduction system and reflection is in your ECG. So you have to know this as well. So now we come into action potential, another 15 minutes, then another half an hour on antiarrhythmics. So action potential, I just want to show the differences between the skeletal versus cardiac muscle action potential. So peripheral nerve action potential is what we call the skeletal muscle action potential, because peripheral nerve innervates your skeletal muscle. So the conduction or signal transmission that occurs in the peripheral nerve causes the skeletal muscle action potential, whereas the signal transmission and propagation in your cardiac system from your conduction to the myocyte is your SAN pacemaker potential, leading to your ventricular action potential, this part. From here, the SA node or pacemaker potential until your ventricular muscular myocyte, cardiac myocyte action potential. Before we go into the differences, the basis of action potential is difference in ion concentration, intra and extracellularly. Okay, so this is your axon. We have intracellular and outside the axon. The two main important ions that involve leave the skeletal cardiac outside. In skeletal and others, the two main that involve in both action potential is your sodium and potassium. So you must know your sodium is abundant in your extracellular fluid, which is around 150 millimole, whereas your intracellular is 15, which is 10 times different. Whereas your potassium intracellularly is 150 millimoles, whereas your ECF extracellular maximum is 5, which is normal. So which is 30 times difference. That drives the concentration gradient or the ionic gradient that makes these differences in your potential, because the differences in ionic concentration give rise to the change in electrical concentration gradient as well. Ions equivalents to electrical. The increase, the differences in ionic concentration creates a electrical gradient as well. Okay, so that is the idea of it. So potassium is abundant intracellularly, whereas sodium is abundant extracellularly. Okay, what are the cations that abundant in extracellular? It is sodium and calcium, whereas intracellular is potassium and magnesium. How do I remember? I told someone last time, I think. Sodium chloride, sodium and chloride both are extracellular. Okay, potassium hydrogen phosphate, KH2PO4, all these are intracellular. Magnesium sulfate, both are intracellular. Magnesium cation, sulfate is anion. This is how I remember. By looking at what we already know, we can know which one is higher, more inside and outside. Okay, bicarbonate is also intracellular more. Sorry, extracellular. So you have to know which one is. So in this point, what we want to talk about is the change differences between sodium and potassium. So before we go into the depolarization, the spike of action potential, we talk about what is resting membrane potential. During there is no movement of ions, the axon is at rest, they will create a membrane potential called resting membrane potential. This is the steady state potential which exists across the cell membrane, across outside and inside. Steady state potential. Resting membrane potential of a myelinated peripheral nerve axon, this is for skeletal, is about 70 millivolt, with inside of the membrane being negative with respect to the outside. Okay, 70 millivolt, which is negative 70 inside compared to the outside. So what happens in step 1, if you look at it, all our cell membrane will have a sodium potassium ATPase pump, and two main things that involve is your the potassium and sodium. So in step 1, what happens is the sodium potassium ATPase pump pumps out sodium against the concentration gradient, because ATPase is a active transporter. We know outside is high concentration gradient of sodium. So to pump it out even more into outside, it's actively pumping out. Whereas sodium, despite as there's an increase in concentration intracellularly, is being actively pumped in using energy, ATP. Okay. The sodium potassium ATPase pumps sodium out of the cell and K plus intracellularly. This pump sets up the concentration differences of sodium and potassium across the cell membrane. They even more increases the gradient. They even more concentrate the sodium outside and potassium inside. Okay. There was a short note I saw in MEd Masters and also a paper from Panska. Write a short note on sodium potassium ATPase pump. I've talked about it during our pharmacology topic in how the drugs work as well. There's a 2 marks or 3 marks. So this is just a short note on that. So you all can. You have to start off as in saying it's a form of active transport. It pumps out sodium out and pumps in sodium in. So, and ATP energy is needed because the flow of ions goes against the natural concentration gradient. This is what I mentioned. Ions move from areas of low concentration to high concentration. Passive movement is from high to low. But in this pump, it's active. So they go from the low concentration to high concentration. Usually passive means wherever there's high, they'll passively move down to low concentration. But here, it's vice versa. Sodium ions are pumped into a cell across the plasma membrane, while potassium ions are pumped out of the cell. 3 sodium go in and 2 click out, creating action potential, repolarizes the membrane. Sodium ions are pumped into a cell across the plasma membrane, while potassium ions are pumped out of the cell. I think this is wrong. They should be this way, right? I think this is wrong. Let me check. This is wrong. Yeah. The sodium ions are pumped into a cell. They should be pumped out of the cell across the plasma membrane, while potassium ions are pumped out of the cell, pumped into the cell. I think this is wrong. This part is wrong. Sorry, I didn't check it. I will get back to you all on that. So step 2, the membrane is permeable to sodium and potassium ions. These ions tend to leak across the membrane down their concentration gradient. Just now, we already concentrated them at one part. We have concentrated them with sodium, and another part we concentrated them with potassium. So now they will go down across the membrane, down the concentration gradient. Membrane is 100 times more permeable to potassium than to sodium because of the higher concentration gradient of potassium as 30 times more. More K plus is lost from the cell than sodium enters the cell. Net result, larger amount of positive charges has left the cell. Inside of the membrane is left with a net negative charge as compared to outside. This is why it has a resting membrane potential of negative 70, which I mentioned here. 70 of negative with respect to the outside, because the concentration gradient of a potassium is even higher compared to sodium. So much more potassium leaks out from inside to outside rather than sodium coming into the cell, thus creating a relatively more negative charges inside. So which is a negative 70 millivolt. That's how resting membrane potential is created. Okay. Development of action potential, peripheral nerve cell membrane. I hope you all understand. I'm sorry about this part of this confusion. I shouldn't have copy paste this. I should have typed it out myself. But these two, number 4, you can just type it out and you can just put this information and this part. Okay, this repolarizes the membrane. Let me get back to it, what they're actually trying to say. Okay, this is how the resting membrane potential is created. So from the resting membrane potential, how action potential is developed. Peripheral nerve cell membrane from stable membrane potential of negative millivolt, 70 millivolt. Membrane is exposed to a current. Okay, there is a stimulus. Current means there's a stimulus. So the membrane potential can decrease. Mean from negative 70, they become negative 50, negative 40, less negative. They're going towards 0. Okay, they're going towards 0, which is, that's how I remember is phase 0, because they are moving towards 0. They're being less negative or more positive. Reaches the threshold potential. Okay, the threshold potential for skeletal muscle, smooth muscle, cardiac muscle is different. They have to reach this threshold potential before the spike happens, before phase 1 happens. The spike happens. Okay, it is differs. In skeletal muscle, threshold membrane potential can be different, or cardiac can be different. So when it reaches the threshold potential, sudden opening of sodium channel, sodium influx. Okay, this is the sodium channel. The passive sodium channels opens up. Higher concentration of sodium outside, sudden influx. So sudden influx of sodium down the concentration gradient into the cell causes depolarization of the membrane, causes phase 1. The membrane potential overshoots and reaches potential of 30 to 35 millivolt inside positive. A lot of sodium comes in from negative 70, they reaches up to 30 to 35. Now the electrical gradient for movement of sodium is now reversed, because electrical gradient now positive is inside, outside negative. So now it's reversed. Sodium channel close. During this time, sodium channel close, but the potassium channels are open during the depolarization, and now K plus moving out of the cell. So the electrical gradient from positive 35 now going down again to negative until negative 70 millivolt, where they reaches the resting membrane potential. So in skeletal muscle, they have phase 0, phase 1 and phase 3, not as the same as cardiac action potential, where you have your 0, 1, 2, 3, 4. Here, the resting membrane potential going towards your threshold membrane potential, that is 1. Then straight away your depolarization phase 1. Sorry, that is 0. Then depolarization phase 1 and repolarization is phase 3. That's all. So phase 0 is from negative 70 resting membrane potential. They slowly reaches your threshold membrane potential of skeletal muscle is around 50 to 55. Okay. The moment it reaches 50 to 55, sodium channel opens. Sudden influx of sodium causes phase 1 depolarization. And then once it reaches a positive for 30 to 35, the electrical gradient is now reversed, and then repolarization occurs with potassium channels being open and sodium channels closed. So potassium potassium leaks out, causing electrical gradient become again negative. If the potassium channels are kept open for a longer time, hyperpolarization occurs, where the resting membrane potential can go even below the negative 70, which is called as your phase 4. Resting potential, sodium potassium pump is the reason why resting potential is involved, is created. Then your action potential, depolarization, voltage gated sodium channels is important. Then repolarization is voltage gated potassium channel, sodium channel already closed. And finally, resting potential, again the sodium potassium ATPase pump. So this is how it occurs. Okay, you can look at the sodium channels and everything. Okay, look at it, all these things. This is your active pump. This is your passive pump. Active pump at resting membrane potential. This is your sodium channel. This is your potassium channel. Again, this is repetition. Stimulus, when it reaches a threshold, goes depression. Let's say from the stimulus is too weak. It's failed to reach the threshold potential of 50 to 55. They won't have any action potential. There's a fail initiation, fail development of an action potential. Okay, and straight away depolarization, phase 0 here, phase 1 and phase 3. And then the resting membrane potential 7. If it's hyperpolarization, they go into a refractory period. During this period, you cannot have another action potential to come in. So sequence again, I think this is just a repetition. I am not going in. Depolarization, sodium channel, repolarization, potassium channels. Okay, this is talking about the activated and inactivation channels, a bit too detailed. You all can read up on your own. I'll just spend another 2-3 minutes before we go into another 10 minutes before we go into antiarrhythmics. Propagation of action potential via synapse, okay, and your axons. So what happened? The brief period of local depolarization of membrane has effects on the surrounding cell membrane. The depolarization phase 1, also causes effects on the surrounding cell membrane. It acts as a current sink. This is the keyword, which causes the potential of the surrounding membrane to decrease also. One nerve action potential causes a depolarization. They act as a signal, a current signal to the nearby cell membrane, where the resting membrane potential started to become less negative towards threshold potential and causes surrounding nerve membrane to develop action potential as well. When these decrease has reached the threshold potential, surrounding membrane also briefly depolarize. The process is repeated and the net effect is the movement of a wave of depolarization, repolarization down the axon. This is what we call a propagation. From one, it causes the nearby one to depolarize, nearby to repolarize. That's the propagation. The propagated change in potential is known as the action potential. Sodium and potassium channel, voltage gated channel, they open and close in response to specific membrane potential. Channels which open and close in response to chemicals, neurotransmitter are ligand gated. These are different, sir. So these are voltage gated. Here we are talking about voltage gated channel. Whereas when you have acetylcholine norepinephrine, there's a ligand gated channel. Just to highlight this. This is how the propagation works. Okay, in response to a signal, some end of the axon become depolarized. The depolarized spreads down the axon. Okay. So from here, it moves to here. The initial depolarized axon will repolarize now, where the one in front is resting. From here, it depolarizes the other side and then become depolarized. Even though this one is depolarizing here, but this one cannot develop an action potential because they are in a refractory period. It moves. That's why it makes a one way of unilateral movement of a action potential. They don't cause a backward action potential because the axon before is still repolarizing or in a refractory period. So it makes a one way of your downward direction of your action potential. So this is again when sodium channels are open here, the next one is free. So when sodium channel opens here, potassium channels are open here, so they cannot depolarize the behind part. Just to re-highlight on that part. Okay. Skeletal muscle action potential, again repetition. All these are repetition. I am not going into this again. So just to compare with smooth muscle action potential, smooth muscle action potential, they don't actually have this kind of a very clear phases. Okay, action potential in smooth muscle, they are spike potentials or action potential plateaus. Honestly, I also don't understand them much, but it's not very important. Nobody will gonna ask you on smooth muscle action potential. Just remember, it's called spike potential. Okay, smooth muscle potential are called a spike potential. Duration is around 10 to 50 milliseconds. They can be generated by electrical, hormones, neurotransmitters, stretch or spot. Because you know, stretch receptors in your vessels can cause vasoconstriction or vasodilatation. Yeah, they all are smooth muscles, right? Hormones, your norepinephrine, adrenaline, all these can cause vasodilatation, vasoconstriction. Okay, they can be stimulated or inhibited via a lot of things. There is no specific channel. Like we talked about skeletal muscle, they are voltage-gated sodium and potassium channel. Here, it can be many. It can be mechanical, it can be ligand, it can be voltage. So it has a spike potential. Whereas cardiac has a action potential with a proper plateau. This is comparison with your skeletal and your smooth. This is your skeletal. Okay, this is your smooth muscles, spike potential, and this is your cardiac. Okay, these are differences. So action potential in the heart, now we come into two main things in this. It has a pacemaker potential or SAN potential and your ventricular potential. We talk about pacemaker potential first. Pacemaker potential is somewhat similar to your skeletal muscle action potential. Okay, but just that the channels that involve is different. In your skeletal muscle is sodium and potassium, whereas in cardiac, pacemaker action potential is calcium and potassium. Okay, so we have space 0, 3 and 4. Here they call it phase 0, 3 and 4. Okay, in a different compared to your skeletal muscle. Okay. I just want to show one part. Where is it? Where is it? Okay, you see phase 0, 3, 4, whereas in cardiac axial potential is 0, 1, 2, 3, 4. Okay, you just have to remember here the differences in pacemaker potential. Usually the spike, the depolarization is always called as phase 1, something like phase 1. Whereas in skeletal muscle, you see this part will call as 0, this is 1 and 3. Whereas here in pacemaker potential, the depolarization part is what they call as the 0. The one that upstroke is what they called as 0. Okay, so in phase 0 is your calcium influx, rapid depolarization. Whereas in skeletal muscle, the rapid depolarization is due to sodium channels, sodium influx. Here is the calcium influx. And then your repolarization, your downstroke is due to calcium efflux repolarization, which is the same as skeletal muscle, phase 3. And phase 4 is slow depolarization. Okay. Why there is a difference in pacemaker? Pacemaker has a slow and fast depolarization. Whereas in skeletal muscle, the slow depolarization they call as from resting membrane to threshold potential. They don't actually label it as slow depolarization, but actually it's almost a similar phenomena. Okay. So here the slow depolarization occurs. Slow depolarization is sodium channel, phase 4, which is also carried as a funny current channels. Okay, it has sodium channels, mainly sodium influx. Then once it reaches the threshold potential, your phase 0 start, which is a rapid depolarization due to calcium influx. Then phase 3 will be your potassium efflux, leading to your repolarization. So phase 4 is your funny current channel and T-type calcium channel. T-type is a slow calcium channel. Phase 0 is rapid calcium channel, which is L-type calcium channel. And then phase 3 is voltage gated potassium channel. Okay, this is voltage gated potassium channel. So what happens? You see in these they write 1, 2, 3. This 1, 2, 3 does not correlate with 0, 3, 4. This 1, 2, 3 actually 1, 2, 3. What happening here? Okay, they didn't actually label it as phases, because that's why I say most of the time you don't have to label it as phases. You can just write a depolarization here, repolarization here. Okay, because some books mention different numbers. So pacemaker potential number 1, this is the slow depolarization due to opening of both sodium channels and closing of potassium channel. Notice that membrane potential is never a flat line. Compared to skeletal muscle, your resting membrane potential, there will be a plateau. In cardiac also, there will be a plateau. Whereas here, there will never be a plateau. It's a slowly coming. That's why it's a funny current channels. And also here, the sodium and also the T-type slow calcium channels involved. Whereas the upstroke is the fast depolarization due to calcium influx. Okay, rapid calcium influx. And repolarization due to potassium efflux, which bring down the membrane potential again back to negative. Remember, this much is enough. This part is sodium and slow calcium T channels. Here, rapid calcium L-type calcium channel. Repolarization is potassium efflux. Calcium influx, potassium efflux. This is sodium and calcium influx slowly. Slow calcium and sodium influx, fast calcium influx, potassium efflux. Next, we bring it to a cardiac myocyte action potential. So this is the difference between your SAN potential where there is a plateau. So here we have phase 0, this phase 0, which is similar to your phase 0 here. This is difference here in this phase 0. Okay, but if you look at it here, this phase 0, what they call as influx, from the resting membrane potential up to reach the threshold potential. Phase 0, influx of sodium. Then you have upstroke, phase 1, transient. Why is it like this? Yeah, okay. This is your phase 0. This part, the upstroke. The differences between your SAN and here again, the upstroke is similar to your skeletal muscle, because now we are talking about myocyte. There also myocyte, skeletal myocyte, yes, cardiac myocyte. In myocyte, the upstroke is your influx of sodium. So phase 0, influx of sodium. And then we reach phase 1 when they reach the positive 30 millivolt. phase 1, which is transient influx of potassium slowly, and then they come into a plateau phase. Plateau is maintained because influx of calcium and sodium. If there is no influx of calcium and sodium, this influx of potassium will bring down this action potential down to negative. But it become a plateau because there will be an influx of calcium and sodium, maintaining the electrical gradient here, electrical voltage. Okay. And then after that, phase 3, where your potassium efflux more than calcium and sodium influx, the repolarization occurs. And phase 4, again, sodium potassium pump comes into play to re-establish the resting membrane potential. So you see the similarity between your cardiomyocyte and skeletal myocyte. It mostly correlates. The fast depolarization is because of the sodium influx, and repolarization is about the potassium efflux, and resting membrane potential is established via the sodium potassium pump. The distinguishing feature between skeletal and cardiomyocyte is this plateau. This plateau in cardiomyocyte, which causes the refractory period, because of the influx of calcium and sodium in between the repolarization phase, which maintain the electrical gradient. So opening of voltage gated sodium channel, phase 0, then phase 1, transient output of flow of potassium, opening of L-type voltage gated sodium channel and sodium influx also here, maintain this plateau. Then finally calcium channel inactivate, potassium continues to flow out, causing this. So you have to know the value of refractory period, which is absolute and also relative. Okay, I'm not going into that depth. So this is totally is around 250 millisecond. The absolute is around 200, another relative around 50 millisecond. The importance is in a relative refractory period, another action potential can comes. But during the absolute refractory period, whatever the signal comes in, they cannot create another action potential. This is how there is a natural phenomena which prevents arrhythmia, irregular conduction and contraction of the heart. But whereas in relative period, another action potential can comes in. So rapid depolarization from a resting membrane potential of 90 compared to skeletal muscle, which is 70, the repolarization occurs the threshold potential. Then it goes up to positive 30, same like your skeletal muscle. Then the plateau is mainly because of your calcium channels open and calcium channel close, and repolarization occurs. Just repetition again. Okay, the propagation in cardiac muscle compared to skeletal muscle is via the gap junction. I just want to highlight this. Okay, the gap junction, myocardial cells have a specialized few features like syncytium and gap junction. This is how propagation occurs in cardiac muscle. So pacemaker versus contractile, will be asked in SAQ or also in Viva. You have to able to draw like this. You draw a cardiac myocyte action potential and you superimpose your pacemaker potential on top of it like this. Very clearly show the pacemaker potential does not any straight line, no plateau. It's a slowly going up and rapid going up, rapid downstroke, and slowly again re-establishing. Okay, compared to your ventricular myocyte, the resting membrane potential of pacemaker is much less negative compared to your myocardium, which myocyte, which is negative 90. They both comes up to almost 30 around there. Okay, the maximum should. This is what your ECG looks like, your QRS complex. The rate corresponds to your QRS complex. Pacemaker versus cardiac muscle action potential. Pacemaker potential occurs in pacemaker cell driven by funny current channels, whereas it occurs in where cardiac muscle occurs in your ventricular muscle side driven by stimulus. Okay, this one is a automaticity. It has your own stimulus, a funny current channel continuously going. That's why there is no plateau. Whereas cardiac muscle, they need a stimulus, no funny current sodium channel. The resting membrane potential is unstable. That's why it's always moving. It's not a plateau, which is negative 60, whereas here is stable, negative 90. They can see a plateau here. Only 3 phases, 0, 3, 4, where it has 0, 1, 2, 3, 4, 4 to 5 phases, like we call it 1, 0, 1, 2, 3, 4, 5 phases, actually 4 to 5 phases. Automaticity is possible. This is automaticity. There is no rhythmicity here possible. These are the 5 different. If they ask you to differentiate pacemaker versus cardiac, you draw this, or you can superimpose like this, or you can draw like this too, and then write these things is more than enough. Okay, again, the differences shown in one picture. 0434. Okay, I'm just showing it here. In Carey-Brandis, they actually have a lengthy, extensive differences between ventricular muscle cell and SA node cells and everything. Please read about it. These are the thing. They actually mention how they differ in duration, the way they stimulus, the response, the resting membrane potential, and how they block and everything, conduction velocity. Very good. Please go and read in Carey-Brandis. So skeletal muscle versus cardiac action potential. There are similarity and the differences. The similarity, I've talked about it. The rapid depolarization is about sodium influx. They both have a stable resting membrane potential. They do have a refractory period, but in a cardiac, the refractory period is even longer. Okay. The main differences, the duration of the action potential of a skeletal muscle is only 5 to 10 millisecond, whereas for cardiac myocyte is 250 millisecond because of the lengthy refractory period. You look at your skeletal muscle, this is your refractory period, which is very short, absolute versus relative, very short, whereas your cardiac, it is lengthy, very, okay. And absence of plateau, you see here there is a plateau after the depolarization, before repolarization occur, whereas here from depolarization, immediately repolarization, there is no plateau. Absence of a pre-potential. What we meant as a pre-potential is this part. The slow rise here, this part. Okay. This part does not usually have in your skeletal muscle. It just goes like that, then straight goes up slowly. They also, as I mentioned, from your negative 70, they will slowly go up. This value may differ, but the normal value for skeletal muscle resting membrane potential that commonly used is negative 70, whereas your cardiac is negative 90. Okay. So actual absence of a pre-potential. Pre-potential is your funny current, pre-potential is this part. When we're talking about this part. Sorry. What I want to say is, okay, absence of a pre-potential in your cardiac. In cardiac, you see from here is directly shoot up. Sorry. So you see, where is it? This part, straight and shoot, goes up like that with the stimulus, whereas in your skeletal muscle, you will have a pre-potential. If I'm not mistaken. If I'm mistaken, please correct me. Yeah, sometimes, you know, when you present, you might get confused as well. I don't, that's what I mentioned here. So refractory period mean there is no response. Absolute, there is another action potential cannot be developed. Relative, this is asked in Viva. What is the difference between absolute versus refractory period? Okay. Skeletal muscle have only 2 to 3 minutes or milliseconds of refractory period compared to your cardiac muscle. Okay, cardiac muscle have 200 millisecond. Total is 250 millisecond. 200 absolute and 50 millisecond is for relative. Okay, so these are the differences. Okay, now we go into antiarrhythmics. There's not much, very short. So famous question about antiarrhythmic, you must know the classification. Vaughan-Williams classification or Singh-Vaughan-Williams classification. Basically, it's a classification based on the action on site of the ion channels. Okay, it's not a classic clinical classification. It's based on the ion channel, which ion channel is affected. So we have a class 1, class 2, class 3, class 4. Class 1 is sodium channel blockade. Class 2 is beta blockade. Class 3 is potassium channel blockade, and class 4 is calcium channel blockade. So I remember this mnemonic which I found online until now. For class 1 group, you order a McD burger lah, okay? Because last time in MCQ they'll ask following class 1 drugs. They will put, and then you have to memorize this. So how do you order a burger? Double quarter pounder, which is DQP, class 1A, with lettuce, mayo, and tomato. Your ingredients inside. You already mentioned what you want. That is the main menu. What vegetable you want and what dressing you want is lettuce, mayo, tomato is your class 1B, lidocaine, maxilitine, and tocanite. Class 1C is your extra add-on, which is fries. When you order burger, they'll ask add-on, right? So which is more fries, please, which is morizine, flecainide, propofenone. Out of all these, I think we only use lignocaine. Okay, I don't think so far in my anesthesia practice, I never seen disopyramide. Quinidine we use in anti-malarial, not as antiarrhythmic. Procainamide I never seen before. Mexiletine, toconate, I've never seen before. All these three I never seen before as well. Okay. Basically, most of them are all are LA, amide local anesthetic. Okay, they all are amide local anesthetic. On lignocaine is very widely used as antiarrhythmics. Okay. Next, you have class 2, which is beta blockers, all finished with lol. You know, propranolol, atenolol, metoprolol. Okay. Class 3 is potassium channel blockade. This is the mnemonic they given, SAT, sotalol, amiodarone, and dofetilide. Got few others also lah. Okay. Sometimes got gadolinium and nothing. The main two thing is sotalol and amiodarone. Okay. And then finally, class 4 is calcium channel blocker, where you have your diltiazem and verapamil. Okay. Uh, so how to remember? You may choose any mnemonic you want. If you don't want any mnemonic, you can remember by yourself also good and well and enough. This is what I used. So what is wrong? The next question in Viva will be, okay, do you think the Sings-Vaughan-Williams classification it's a very good classification. It's the ideal classification anti-arrhythmics. What is the limitation of it? This is a famous question. So the limitation will come into it before this. Before that, just limitation, because main limitation, it does not include digoxin and adenosine, which is a very common antiarrhythmic that is used. When this Vaughan-Williams classification is introducing, they did not include digoxin and adenosine. They didn't put it because it's an ion channel or receptor classification. Digoxin and adenosine works in multiple pathways, so they didn't include it. Another drug, magnesium, which is an electrolyte which we use widely for most of the supraventricular arrhythmia, which is also not included. Okay, magnesium is a wonderful antiarrhythmic. It has multiple hypotheses, multiple mechanism, but there is no specific mechanism that can be specifically put in one of the classes of Vaughan-Williams. And it's not a clinical classification. As I mentioned, it's not a clinical. Clinical as in they are not classified antiarrhythmic based on the indication, like for VT, for VF, for AF, like that. It is a ion channel blockade classification. If you look at it, even all of it, not all of it are ion channel. This is ion channel. Class 1 is ion channel, sodium channel. Class 3 is potassium channel. Class 4 is calcium channel. But class 2 is receptor blockade, not channel blockade. These are channel, ion channels, where this is receptor blockade. Even here, it is not uniform. There is not homogeneous. There is heterogeneity there as well. So it is ion channel and receptor channel blockade. And some agents fall into many classes, especially amiodarone, which has all 4 class activity, and sotalol as class activity 1, 2, 3. Okay, so they don't specifically sit in one class. They might have a multiple mechanism action, so they can be included in many classes. Overlapping similar mechanisms between classes, class 1 and 3. Class 1 and 3, despite being a different channel blockade, they somewhat causes the same effect on the action potential. So these are the few limitations. If you're able to mention these 5, is more than enough to get marks or in Viva. In SAQ, I don't think they have been asked, but Viva, yes. The moment they talk about antiarrhythmia, the question will start with classification. Then Vaughan-Williams is the only proposed and widely used classification despite the limitation, but they will want to know whether you understand whether these are the limitations of it or not. Okay, so next we go into how this antiarrhythmics works on action potential. This is the reason why I started off with action potential. So you see, sodium, we know the phase 0 is rapid depolarization is because of the sodium influx. So if you want to stop it, you have to use a sodium channel blocker which will interfere with this phase 0. So your sodium class 1 will affect the phase 0. We'll come into this 1A, 1B and 1C in a while. Next, we talk about the action potential of this plateau phase. This plateau phase, as I mentioned, is your slow calcium, is a L-type calcium channel. So this is where your slow calcium channels works in. So your class 4 calcium channel blocker will work here. Then we have your repolarization phase, which is your potassium efflux. So your class 3 potassium channel blocker will work here. And finally, beta blockers also works at the phase 4, the hyperpolarization phase or the resting membrane potential establishment phase, where they become a membrane stabilizer here, rectifier. Okay, so we come into this. This is where each of the anterior. If they ask you to show, you just draw a cardiac action potential, label the phases 0, 1, 2, 3, 4. Then you show your sodium channel class 1 antiarrhythmics works here, class 4 works here, class 3 works here, class 2 works here. Okay, so what we have class 1 sodium channel blockade. We have a 1A, 1B and 1C. 1C has a very strong sodium channel blockade followed by 1A and 1B. This is also asked in MTF last time. What do? They all causes reduction in phase 0 slope because they are sodium channel blockade. So they does not cause this straight upstroke. They make this slanted. They make this stroke slow to rise. So they causes reduction in rate of rise of this slope. Okay, reduce the phase 0 slope and peak of action potential. It doesn't reach all the way to 30 here. So that's what they all do. 1, 2 and 1A, 1B, 1C all do that. But based on how strong is the blockade. 1C has a very strong blockade. So they pronounce reduction followed by 1A, which is moderate reduction, and 1B, weak reduction. Okay, but there is a significant differences between 1A, 1B and 1C in their effect on refractory period. Well, okay, phase 1A increases action potential, duration and effective refractory period. They increases the duration of refractory periods. It get prolonged. Where 1B reduces the refractory period and 1C does not have any effect on refractory period. This is very important. Okay, so remember this. 1A, 1B and 1C, they all cause a reduction in phase 0 slope. But 1C being a very strong channel blockade, we have a pronounced reduction followed by 1A and 1B. But they all have a different effect on the refractory period where 1A prolongs the refractory period, 1B reduces the refractory period, 1C no change in the refractory period. How do they cause it? We come into it. Next, we come to beta blocker. Beta blocker, we know is a sympathetic blockade. Beta agonism is sympathomimetic, or beta blockade is sympatholytic. Block the sympathetic activity. So they reduce the heart rate and reduce the conduction as overall. So that's why they X here, this part, the last part. Okay, they prevent the next action potential to comes in. So they reduce the conduction system. Okay, next, potassium channel blockade acts at the repolarization phase. So they delay the repolarization phase. So they lengthens the refractory period. They make the repolarization longer. So next action potential cannot comes in. Okay. Finally, calcium channel blockade. What they do, they block this low calcium channel. Most effective at sinoatrioventricular road. What they do, they reduce rate and conduction, same like beta blockade, because we know calcium is sympathomimetic, same like beta agonism. When you block it, you're causing blocking sympathetic activity, so you're reducing chronotropy and dromotropy. Chronotropy is heart rate. Okay, chronotropy is the heart rate. Chronotropy is your heart rate, inotropy is your contraction, dromotropy is your conduction. So what antiarrhythmic do? They reduce the rate, they reduce the chronotropic effect, and they reduce the conduction, they reduce the dromotropic effect. Rate control and rhythm control. Antiarrhythmic have rate control and rhythm control, right? So rate control is the reducing the heart rate, reducing the conduction is the rhythm control, bringing back to the normal rhythm. So where do they act? We talked about where do they act in the, this is the same as this part. Okay, this one. Where do they act? Class 1, class B and everything. Okay, you say beta agonist blockade at phase 4. Class 1 memang a rapid depolarization. Class 2 beta blockade also acts here, this part. And class 4 at the plateau pace and class 3 at the repolarized pace. Where do they act in the heart anatomically? Okay, we can see class 1, 1A, 1B, 1C, they all mainly act at the bundle of Is and also the Purkinje fibers. Okay, atrial conduction, all this, the conduction pathway. Whereas your 2 and 4 is your beta blocker and calcium channel blocker. They block the sympathetic activity. So that's why they directly affect at the sinoatrial node, thus reducing the rate. Your SA node controls your heart rate. That is your heart rate determining sensor. That is the heart rate setter, sinoatrial node, right? We have that's why SAN rate and AVN rate. Okay, ventricular rate and SAN rate. So class 2 beta blocker and class 4 calcium channel blocker, they are sympathetic activity blockade. So they directly affect an SAN. Whereas your class 1 and class 3, they work at the conduction pathway. They work at the AV node. They also work at the Purkinje fiber and bundle of is to understand. You have to correlate the anatomy to the electrical activity of the art to understand antiarrhythmics clearly. Okay, we have went through this. Okay, very quickly regarding the how do they each of the classes work. So as I mentioned, class 1 sodium channel blockade, they effects on sorry, this one my mistake, not repolarization, depolarization, effects on depolarization, D. So they affects the depolarization, the upstroke of phase 0. So what happened? They cause it reduction in the rate of slope of phase 0. The kinetic or interaction with sodium channel differs based on the how strong is their blockade. We know 1C as the marked sodium channel blockade. So you can see the slope is memang slanted a lot. But since they slanted a lot, the amount of refractory period, the repolarization comes in here. So that's why there is no change in refractory period. It reaches here and then it's straight away short action. It is a strong and short action. That's why the refractory period is not changed. Next, we go to 1A, 1B, 1 as the marked sodium channel blockade. So it's very short but very strong. That's how I remember. Next, we go to moderate sodium channel blockade 1A, which has a moderate blockade and moderate action, moderate duration of action. So what they do, they prolongs the repolarization period. 1C, no change. 1A as a prolonged repolarization period. Whereas in 1B, they have a mild sodium channel blockade. They practically does not do anything to the action potential. You can see the rate of phase of 0 is only slightly altered. So there is not much change in the morphology of the action potential. Thus, there is the action potential is slightly only shortened. It's a shortened repolarization. Here it's marked and the effect is prolonged. That's why it's long. Whereas here it is a mild blockade, but the and it causes a shortened repolarization period. Whereas in 1C, it's a marked blockade, but there is no change in the repolarization. Prolonged repolarization, shortened repolarization, no change in repolarization. In Viva, they do ask you to draw this to show differences between 1A, 1B, and 1C. If you're able to show the differences in the rate of reduction, the rate of slope of phase 0, and the change in the refractory period duration is more than enough. I prepared this because I saw one of the paper in Hong Kong or Fanska. Actually, there was SAQ about write a short compare and contrast class 1 antiarrhythmics. So 1A, 1B, 1C with example. So I just pick one of each of it and then did a compare and contrast like this. It is also in one of the online SAQ compilation, either ketamine nightmares or life on the fast lane, something like that. So procainamide, lignocaine, and flecainide, 1A, 1B, 1C. They all are amide local anesthetic. Procainamide is isomer of a procaine. Flecainide also is an amide LA. They all are amide local anesthetic, same like lignocaine. The users mostly use for ventricular tachycardia or supraventricular tachycardia. Okay. Procainamide and flecainide available as oral, whereas lignocaine only available as IV for antiarrhythmics, as in we only inject IV for antiarrhythmic use. Of course, lignocaine used as LA, we give as a subcutaneous, we give epidural, whatever. Here, the uses, what they're talking about is only about antiarrhythmic. So for antiarrhythmic use, lignocaine only used as IV, not anything else. Okay, the dosing, I just kept it here for my knowledge, not important. Just lignocaine 100% bioavailability because it's IV, whereas flecainide and procainamide actually have a decent bioavailability, 70 to 90%. Flecainide is 50% protein bound. Metabolism all by hepatic, just that procainamide have active metabolite, where lignocaine and flecainide. Another important thing why about highlighted active metabolite is the Vaughan-Williams classification. They only talk about the antiarrhythmic property of the parent drug. Some of the metabolites of the parent drugs also have anti-arrhythmic property, which is not included, which is here, the procainamide. Procainamide as an active metabolite also found to have some anti-arrhythmic activity. So that was not as included in the Vaughan Williams classification. If you want to get some distinction point, you can mention this lah. Okay. Then mechanism of action, all of them reduce the rate of rise of phase 0, but just the differences is the prolongs in the RP, but the reduction, the rate of result will be highest in the 1C, followed by 1A, followed by 1B. But prolonged refractory period, shortened refractory period, not effect. Then the cardiovascular effect, let's leave it here. I will share this with you all. Okay. Then class 2 beta blockade is a receptor blockade rather than ion channel blockade. So what happened? Beta blocker, all of them have anti-ischemic effect. Okay, because they are sympatholytic. In a patient with the ischemic heart disease, you cannot work the heart too much. Offload, you have to offload the heart. So you have the anti-ischemic effect. So you reduce the heart rate. So we're reducing the heart rate, reducing the conduction, you reduce the myocardial demand, myocardial oxygen demand, so less anti-ischemic effect. Okay, and some of them have membrane stabilizing effect by reducing phase 0, the effect on the phase 0, inhibit phase 0, the class 1 antiarrhythmics. Okay, they have, so the beta blockers also, even though they're being a class 2, they do possess class 1 antiarrhythmic property. All of them inhibit this resting membrane potential, the last part of it. Okay, so by inhibiting your calcium cyclic AMP, because beta agonism increases your cyclic AMP, beta blockers will reduce your cyclic AMP. So they disturb your sodium potassium ATPase pump and everything. So they do their class 2 antiarrhythmic persistently here. They also have some class 3 antiarrhythmic, especially sotalol. That's why sotalol, as I say, despite being labeled in a class 3 as a potassium channel blockade, but sotalol itself is a beta blocker. So it has class 2 and class 3 antiarrhythmic property. The action potential duration is prolonged. Okay, this is how beta blockers class 2 works as an antiarrhythmics. Class 3, very easy, is a potassium channel blockade. In your cardiac action potential, the phase 3 is your repolarization phase, which is your potassium channel open, calcium efflux, and you stop the calcium efflux, you're going to prolong the refractory period, thus the prolonged repolarization occurs. Simple as that. Okay. Then class 4, calcium channel blockade, again they are sympathetic activity blockade. So what they do, they decreases the slope of phase 0. Where do they act? As I mentioned, you see, this part. So your class 4 and class 2 mainly act at the SAN, pacemaker potential. But class 4 mainly they act on the SAN potential more than the cardiac action potential, because calcium channel blocker action here in your cardiac ventricular myocyte action potential is here. So they can act here. Okay, they can act here as well. But the most important significant way they reduce the heart rate is via acting on the pacemaker potential. They decrease the slope of phase 0. So increases the PR interval. Increase PR interval means reduce heart rate. That's why if you get your heart block, right? How do you diagnose your heart block? By looking at the PR interval. So increased in PR interval, bradycardia. Reduce in heart rate, less myocardial demand. Less in patient with arrhythmia, fast heart rate. That's why they bring down the heart rate. And then they increases the duration or effective refractory period, prolonged repolarization at the AV node. So they work at SA node, they work at AV node. So they mainly in fact affect the nodal effect. They have the nodal effect at AV, SA and AV node. So by increasing PR interval and effective refractory period. So if you look at it here, we mentioned here what they do, block L-type calcium channel, most effective at sinoatrial and atrioventricular nodes. They do affect at the cardiac myocyte at the phase 2 by blocking the L-type calcium channel, but they're most effective at sinoatrial and atrioventricular. They affect the nodal pathway, the nodal conduction first. Okay, that was simplified. So famous SAQ, when I went through the antiarrhythmic, amiodarone is the famous. You must know in and out everything about amiodarone. Next, rather than asking individual, they ask about ventricular fibrillation management and that. Actually, the question was talking about non-pharmacological and pharmacological. I take out the non-pharmacological, I put it here pharmacological. and also about digoxin. Okay, the individual drug of antiarrhythmics, I never seen it coming out as SAQ. Like they we're not going to ask you about talk about quinidine. They're not going to ask you to talk about mexiletine, propafenone, everything. I think you must know for your SBA purposes. Quinidine, maybe they might ask you about some toxicity. Adenosine, yes, you must know about your adenosine. Digoxin, yes. Beta blockers, of course, you have learn it as your antihypertensives. Lignocaine, you already learn it under the PKPD. You have learned under the LA. You just have to know the antiarrhythmic action of it and their side effect, as in local anesthetic systemic toxicity. Okay. So amiodarone, I take from my favorite Matthew Ho. The fellow has done a very good job. So the marks was given as 10 marks as a whole, but I think it's should be divided as such. If I'm the one that answering, the 10 marks I'll divide it into mechanism option 3, pharmacokinetic format because ADME, absorption, distribution, metabolism, and elimination, 1 mark, and major side effect I'll give 3 marks. This is how I would have answered, even though they didn't give it in a point. Now they do the old time, they just mention and give 10 marks. So mechanism of action, amiodarone has all 4 action, 1, 2, 3, 4. So you just reiterate what I've mentioned. Apart from that, they have alpha blocking activity as well, which is not actually included in the classification. So users indication is mostly used in ventricular tachycardia and supraventricular tachycardia, not in VF. Or it is also used in actually you can use your ventricular fibrillation also here. Okay, we have used amiodarone in VF1. Okay, pharmacokinetics, ADME. It's a variable absorption, 40 to 70%. Protein binding is very high, 95%. It has interaction with many other drugs. Large volume of distribution up to 70 liter per kilo, highly soluble in fat, muscle, heart, and thyroid. That's why they affect the thyroid. You can have hypothyroidism effect. Hepatic metabolism, they being a metabolite into desmethylamiodarone, also have a mild antiarrhythmic activity. As I said, this is another limitation. That's why I talk about proconite. So you see even amiodarone as this active metabolite, which is a it's an inhibitor of CYP P450. So any other drugs being metabolized by this enzyme concentration will increase in plasma because amiodarone inhibits it. It's a renal excretion. TF is 1 to 20 days. So in a patient with kidney failure, patient with liver failure, we are worried about giving amiodarone. That is the reason. Okay. So and CVS side effects. Main thing we give fast, patient can get hypotension and bradycardia. You all know this. Respiratory, very important, pulmonary fibrosis in a patient with the ARDS, patient with the lung issue, or patient with the chronic lung disease. That's why we try to avoid amiodarone. CNS, they cause is corneal microdeposits and peripheral neuropathy. Endocrine, this is very important, hyperthyroidism and hypothyroidism. The risk of hypothyroidism is higher than your hyperthyroidism. Okay, hypothyroidism, it reduces the function of thyroid because iodine content in amiodarone. They cause a blockade, and they also blocks peripheral conversion of T4 to T3. So hypothyroidism, the active thyroxine is reduced. Okay. But it also do cause hypothyroidism, but it's the relatively hypothyroidism more. Hepatotoxicity, you all know about it, causes transaminitis. Skin, in a long continuous infusion, they do say it causes a skin description blue gray, but it causes photosensitivity. Drug interaction, inhibitor of hepatic CYP450 metabolism. It displaces highly protein-bound drugs. Synergistic antiarrhythmic effect with the other antiarrhythmic, especially calcium and beta blockers. Increase in QTCs with TCA, droperidol, pinothazone. The risk of bradyarrhythmia is even higher if you give it together. Okay, there's drug interaction. Anesthetic problem, hypotension, AB block, ARDS. I think you all know this. This is this extra. So the marks is for this 3 marks, another 4 marks, 1 marks for each of these, then another 3 marks. You just no need to go in depth about it. Just choose. CBS, you can just hypotension and bradyarrhythmia. Respiratory, you can mention about pulmonary fibrosis. CNS, corneal microdeposit. Endocrine, hyperparathyroidism. GI, maybe 0.5 marks, around 6 points here. Okay. This again, the major side effect. This how I will give 3 marks lah. Maybe 0.5, 0.5, 0.5, 0.5, 0.5, 0.5, 6. You get 6 points, 3 marks. Next, outline the pharmacological treatment of VF. But whenever people ask you to manage VF, you cannot directly go into pharmacological. If I'm the one answering SAQ, I may start off introduction with this. Okay. VF is patient is in cardiac arrest for sure. You have to CPR. It's a shockable rhythm. So I will just mention about the non-pharmacological management, as in VF, start CPR, rhythm is shockable, then we shock with defibrillation of 200 joule if it's a biphasic, or 360. But don't write too much. Keep it to 2-3 sentence, or you can just write like this. Just write like this is more than enough. Okay, VF, CPR, 5-cycle, rhythm shockable, I think, because we are anesthetists, of course, we don't only give medication. Unless the question specifically mentioned as what I've mentioned here, feel free to leave this away. Okay, feel free to leave this away. Okay, so the drugs that used, of course, we will start CPR. So you have to give adrenaline. So you have to mention adrenaline is given as a part of CPR. So mention about adrenaline, what is it? So you see the mark, if it's 10 marks, they mention specifically pharmacological. You just choose 5 drugs and divide it is 2 marks for each drug, something like that. Okay. So adrenaline, I just give a extensive answer here. But you don't have to write too much. You just mention adrenaline. I think maybe you get 0.25 mark. Dose 1 mg given during CPR with a rate of 1 to 3 minutes in between. What does it do? It causes a peripheral vasoconstriction, increased coronary perfusion, increased inotropy, increased chronotropy, everything. Side effects you want to mention, you don't mention also, never mind. Then amiodarone, of course, where do you give? You give in a refractory VF after 3 cycle of shock. Okay. Sorry, after second shock. Okay. After the first shock, you give adrenaline. Sorry, what am I saying? After 2 shock, you give adrenaline. After the 3rd shock, you give amiodarone. Okay. So you have to mention that. Then amiodarone as all 4 antiarrhythmic properties, and then we have discussed about it. You can talk a little bit about amiodarone. Then you can talk about lignocaine. Dose is 1 to 1 milligram per kilogram. Second line after the amiodarone for refractory VF after the shocks, after the 3 shocks. So mechanism of action, class 1B. What do they do? You mentioned here. Understand that is a question on antiarrhythmic. So you have to mention about the antiarrhythmic properties of the drug which is used, like amiodarone and lignocaine. Adrenaline is not, but it is used in a VF management. Next, vasopressin used as in case of hypotension. If you miss this out, also never mind. Okay, vasopressin, if you don't mention, also never mind. Okay, I would not remember vasopressin. I would have remembered magnesium and bicarbonate. Okay, magnesium, yes, we do give during the VF if it's a COSATs, if it's secondary to TOSATs. So 5 millimole IV slow push. That mechanism of action increases the membrane stability, competes for calcium, so it reduces the heart rate. Then bicarb, of course, the VF patient CPR will develop metabolic acidosis. So to correct the metabolic acidosis, dose is 1 millimole per kilogram, as acts as a buffer, something like that. Okay. So what I've given here is the whole answer. As I always say, you must know your level, your potential. What is your time frame to answer SAQ? Prepare an answer scheme or template for in your capability, which you can answer within 20 minutes. Okay. Next, about digoxin, I'm not going to give the answer. Digoxin, you have know the mechanism of action. Mechanism of action of digoxin is quite peculiar. It acts at multiple level. I will share the answer later. We can discuss another day, but please do the homework, read about it. And you know about the pharmacokinetic of digoxin. It is very peculiar as well. It has many interaction. It has a very narrow therapeutic index. Its interaction with the potassium is important. Then toxicity and management also important. Okay, please do the homework. That's all for today.